Welcome to Human Centered Health, a podcast exploring the challenges facing healthcare. The pandemic exposed weaknesses in our system while illustrating how it should be redesigned to empower caregivers and improve patients' quality of life. Listen in as your host, Vic Gatto, dives into complex and emotionally charged topics with diverse leaders across the industry. Human Centered Health, your new perspective on health starts now.
Hi, everyone. Thanks for joining Human Centered Health. Today, I have Ted Merhoff, who is the Chief Strategy Officer for Shearwater Health. I've known Ted for a long time. He actually was on the first management team I invested in as a VC about 21 years ago. And he's a great person. He has been focused on really addressing the workforce shortage in healthcare, especially in nursing. And of course, he's been working on this for a long time. It's become critically necessary in the post-pandemic world. I think you'll really like to hear what Shearwater is doing. They have ideas about bringing new nurses into this country, and also a thing called clinical process outsourcing, which is really going to be an important component to the solution. Please listen to my interview with Ted Merhoff. Thanks. Welcome, everyone, to Human Centered Health. Today, I'm excited to have Ted Merhoff. He's the Chief Strategy Officer at Shearwater, and I've known Ted, probably 20 years. I think what used to be HCH near Shearwater was one of my first investments as a VC. So great to come full circle and get an update.
Terrific to see you too, Vic. And you are among the first people that I met in Nashville. So it's fun to have this discussion after having worked together.
Yeah, we both were young and innocent, trying to figure it out 20 years ago, or maybe more than 20 years ago. So, so give the audience a little bit of your background and Shearwater and kind of what the company does and your role there.
Yeah, please do. So, Vic, I started my career as an orderly in a pediatric trauma center back in the late 80s. And from that first experience, developed an appreciation for the delivery of patient care, and particularly for the impact of registered nurses on the way hospitals operate. I went along a pathway where I thought my career ambition was to be part of a team running hospitals or a group of hospitals, and then took a pretty hard left turn in 1999 when I moved to Nashville and joined a company which had a long legacy of operating hospitals outside of the United States. And the purpose of joining the company was to help build a hospital in Poland, but the way to pay the bills was to recruit physicians from North America. And I did that in connection with my colleagues in Western Europe and Southeast Asia, all of these healthcare workers leaving their home countries to go work in another part of the world. And that's how my time here began.
Yeah. And so that was in 99 when you joined. The company's done lots of things, starting off with the hospital in Poland. Talk about the nurse side of things. As you mentioned, that's a critical aspect of need, both globally and in the US. And then I think the company's made several growth additions.
Yeah. I thought about from my time wearing whites, working in the emergency department, and then later listening to the CFOs of the hospitals where I worked, there was always a consistent story about the shortage of nurses and the alternatives that hospitals had to solve for their staffing deficits. And the ones that were most often used by hospitals where I work, indeed by hospitals across the United States, are contract labor or travel nurses. And those nurses fill a very valuable role for short-term gaps. But I've once worked with a chief nurse executive who told me that travel nurses are great as a staffing strategy, not very great as a recruitment strategy. And the vision for what today represents half of the focus of Shearwater Health really came to be a reality on one of my trips in the Middle East. Those were the hospitals that we were staffing at the time, and you'll remember that was a big part of our company's history and revenue when you and I first met, and the business plan to bring nurses to America was presented. But on that trip, it was actually a weekend. We weren't having a very big workload that day, and we're thinking, what should the future of the company look like? And among the ideas that I discussed with the then CEO of the organization was a concept to bring nurses to America, to turn our company inside out. And in bringing nurses to America, we knew we could help realize the ambition of so many people who sought a career in nursing in part so that they can move to another country. But we could also create a business model that I had learned from the CFOs and the CNOs where I'd worked that would be an arrangement that would be very difficult for a hospital to say no to. In a sense, a full-time nurse at a lower cost than using a travel or contract labor nurse who has an ambition of living and working in the community where this hospital is located, ideally for decades to come, perhaps for the rest of their career. So that began the first big transition of the organization with the support of a number of investors back in 2002. We began to recruit nurses to America and offer the chance for nurses and their families to chase their rainbow to the United States.
Yeah, so that's kind of the, a version of the American immigrant dream, right? So the two sides of the value proposition are a nurse who has all the appropriate training and licensure, but is not a U.S. citizen and it was born elsewhere, born a global citizen, but not here. They want the opportunity that you and I enjoy here in Nashville, that most of my listeners are U.S. based, that sometimes I take for granted. They're really motivated to improve their life for themselves and for their family and their future generations by immigrating, coming to America. And simultaneously, the health systems that were your clients, like you say, as opposed to a 90-day travel nurse stopgap, these nurses come in, they move to the city, and their intent is to stay for full-time in engagement. Like every full-time employee, life happens, and after a year, 2, 3 years, maybe they go somewhere else, but they're not a temporary solution. They're very different than that.
Indeed, Vic, we set about a strategy where our mission was focused on having the nurse thrive. And we want to have a relationship with our clients. It was true then, it's true today, where we're not competing with our clients to move nurses to another location. So we'll measure success not by whether the nurse arrives, but does the nurse arrive and perform and remain? And when all of those things line up, it's a terrific outcome for the nurse, the patients that we serve, and our client partners.
Yeah. Excellent. Well, that's a great background. As you know, this podcast is really examining from all different parts of the elephant, the workforce challenges. With COVID during the pandemic, we had these underlying shortages. I mean, you've been working on it for a long time, but it got catalyzed and much more dire post-COVID. And I really think the care delivery model needs to be redesigned. So that's why I started this podcast to look at different parts of what could be a solution. Give me your point of view of the workforce challenge with U.S. hospitals, and what can they do? What are really easy and maybe fairly straightforward things they can do to make improvements on that?
I smile because I think about there's so many barriers to actually realizing the vision that I just described to you over the last few minutes. One of the, let me just highlight a few of them. The nurse has to be educated equivalent to U.S. standards, pass English proficiency exam to meet government requirements, pass the U.S. boards, just like any other nurse in the United States, and then receive a visa. And I'll kind of hang on that point for a moment because the U.S. government issues visas. And when those are in supply, the nurses are able to arrive. When they're not, queues begin all over the world, nurses literally waiting to move here. When the economy went through the recession beginning 2007 to 10, we simultaneously ran out of visas, and the U.S. government was not quickly issuing those visas. So we had a pause where we had to figure out, how does our business thrive when our ability to get a nurse in the United States is limited by U.S. government action? Literally, we had 1,000 nurses credentialed in the United States who could,
ready to come,
who could work at any academic health system in the country, but couldn't get here because of the visa. And that realization simultaneously happened at the same time our company started looking at other care models. And in some of those instances, we looked with a bit of envy. This is around the time that the disease management industry was really booming, and health plans were talking about value-based care arrangements and population health. And what we observed were that so many nurses were leaving their bedside practice because you could work from a lot of different locations. Now, at those times, they were mostly from office buildings, but those could be offices run by hospitals or by insurance companies or by third parties. And the irony is we're bringing a nurse from 36 countries around the world to work at the bedside, in part because nurses are leaving bedside practice to go work remotely. And that phenomena has been happening continually over the last 20 years. COVID really put a spotlight on it. In fact, Vic, we're doing this video today on April 14th, 23. And yesterday, the National Council of State Boards of Nursing released a study that showed or indicated 100,000 nurses left the workforce during COVID. 100,000 nurses just exited the workforce. And by their estimation and by their survey, they predict another 800,000 nurses will exit the workforce within the next 5 years. These nurses aren't all retiring. They're finding other places to work, and it's creating a real vacuum inside the acute care hospital environment. Where will you get a nurse? So what we're really excited about today is continuing to place nurses at the bedside, but it's also the capacity to align U.S. licensed registered nurses and other professionals remotely who can work through technology to help drive care improvements in the United States and elsewhere around the world. There's a fundamental shift in the way hospitals are managing their nurses or structuring patient care or pushing care outside the four walls of the hospital, including into the home. And there's a terrific opportunity for nurses working in the cloud, so to speak, to drive care outcomes. And we're really excited about that.
So let's linger on that for a moment. So the in the 08, 9, 10, you started seeing this maybe begin to manifest, possibly because of other macro factors, and also the immigration got constricted due to political reasons, probably.
Supply and demand.
Yeah.
I don't think it was a specific decision that said we don't want more nurses in the United States. It's just the supply of visas. And when a nurse comes to America, he or she may bring family members, and those family members also obtain visas. So that can impact the total number of available visas.
Yeah, and just I may, unintentionally show my politics a little bit, but why does it matter how many nurses we give visas to for the United States? I mean, I know it's a political football that people argue about, but I can't imagine why we would not want high quality, English trained, U.S., board certified nurses to come if they want to come. We need those workers, and it's hard for me to imagine why that wouldn't make sense. So the supply and demand argument, I understand there is an artificial constraint on the number of visas, but I don't see why that is needed. Is there any reason that is not politically motivated?
Vic, the nurses or the visas that we utilize for our nurses are green cards or employment-based visas. And it's not that someone in the United States government is saying we don't need any more nurses. It's more about the total number of immigrant permanent residents coming into America. And there are other ways that people come to the United States other than with a permanent residency visa. There's the H-1B visas you hear a lot about in the technology space. There are training visas, visas for people to come to school. So the U.S. government has a policy on the number, the logic behind the number, and classifications within that number are fiercely debated. Unfortunately, that's something that we can't control, though we try to help educate policymakers as to the shortage of nurses, and the National Council's report yesterday should help drive home the fact that with roughly a fifth of current nurses contemplating exiting within the next 5 years, that is going to create a terrific hardship on our acute care hospitals. And
there's
no the world is just one way among others to help solve for that.
Yeah, and so no question, you could see the trend lines when we're going to need a lot more nurses several years ago. But I want to get your feelings about the impact of COVID. I think it really accelerated the problem in the sense that the entire society that we live in went through an existential crisis. I mean, we were worried about life and death, and everyone kind of looked in the mirror and was trying to think about, well, what am I doing with my day, and re-looked at their job and what the role of work is. And a lot of the jobs, nurses and nurse assistants and lower licensure roles, pretty hard work for not that much pay. And so my view is that the trend lines were already in place, but COVID really accelerated that because there were lots of alternatives that people could do.
And it was a stressful time for everybody, as you described. Our nurses were no exception to that. We had a lot of really worried team members that were afraid for their own health. At the beginning of COVID, we had that compounded by the fact that a lot of our hospitals were closing beds, clients, hospitals across the United States. So suddenly we had nurses that didn't have a place to work. We continued to pay our nurses during that time, and it didn't take long before that pendulum shift swung back, and now the nurses were in great demand. And that's when, just really through the hardest part of COVID, our nurses worked so diligently.
Some of them, and the nurses and doctors were on the front line of the COVID war, like really, literally saving lives and running towards the crisis, which was really valuable. And so let's talk about the other side of your business. So for a long time, you've been helping find nurses, teach them what it means to come to America. It's not for everyone. There's a lot of change, of course, traveling across the world. But that's a great service to sort of bring in. How many nurses a year, how many nurses in general can you bring in from other parts of the world to the U.S.?
Vic, we don't publish our arrival metrics. That's sort of a secret around here. But when we welcome a nurse, the nurses who will arrive this week are nurses we began a relationship with typically 2 or more years ago. Yeah. So we always have visibility into the nurses who are arriving now. And what I would say today is almost any one of our client partners would be pleased to take or receive to their full-time team, not only all the nurses that have already matched to those hospitals, but every other nurse that we have available. To the demand is just.
That's fine to not say the exact number. If 100,000 have left and another 800,000 are going to leave, I'll get that report and put in the show notes. People can review. But give me a frame of reference. Like, there's not enough nurses in existence, and of course, these other countries also have aging populations and nurse needs.
Yes.
Is it possible to solve all our problems with? I think it's probably not. So you need.
No way.
There, yeah.
No. I've worked with one CNO comes to mind. She had a very interesting saying that there were only so many places to get a nurse. And her view was that her HR team needed to hire and compete locally to get every nurse that they possibly could, to expand the funnel a bit more regionally and nationally. To use travel nurses or contract nurses, again, as part of the staffing strategy, but not part of the recruiting strategy. She had a saying about, she called them the tired and retired nurses, trying to create a pathway for nurses who maybe no longer wanted to work a 12-hour shift, but wanted to be a contributing part of the nurse workforce to come back into the nursing world. Creating new nursing schools in the United States, critically important. Although the National Council of State Boards of Nursing report yesterday paints a grim picture around the satisfaction of new nurses in the market, particularly those who've been educated within the last 10 years. I attended an event in Chicago last week, and a chief nurse officer actually wrote about this on a blog a couple of days ago. She said, we love our new grad nurses and we really need to help them. And this is an interesting point, that some of the novel approaches that we're seeing in the market include virtual nursing. These are programs operated by hospitals in the United States that have nurses working remotely. And spoke with the CNO, one prominent system that is known for having a virtual EICU, a virtual nurse monitoring center. They're very proud of what they've accomplished, the technology. They've proven that impact can be created remotely. As that health system scales its virtual nurse program, they have almost 1,000 full-time nurse vacancies at the bedside. So when you think about a nurse entering that employment market, where should the nurse be employed? And we've got virtual nurse opportunities. We have 1,000 vacancies at that system at the bedside full-time, more if you count the part-time nurses. So I think what COVID demonstrated, to your point about the impact on the nursing market, are that nurses can work from a lot of different locations. Technology can enable portions of work to be performed elsewhere. And what we're really focused on now is how can we perform those functions remotely, utilizing Shearwater Health employed nurses, so that nurses in the local market can be closer to the patient, providing direct patient care, or serving as a mentor to those newer nurses who really need the support and the additional experience that was difficult to come by during the times of COVID, when teaching programs weren't the number one thought on acute care hospitals' minds.
Yeah, so talk about that partnership opportunity. You have takes a couple of years to get nurses through the validation process, through the innovation process, but you know their quality, English speaking. You have them vetted probably well before the visa status is.
Oh, yeah.
And so you have whatever the number is, it doesn't matter for the privacy, but there's a lot of nurses that are in the queue, that are out in the world, that you know their quality levels and you're in touch with them. Is there a way to utilize that that resource effectively in partnership with U.S. hospitals in a way that's virtual? I think we put that in place.
In fact, Vic, in 2010, we launched the clinical process outsourcing side of the business, CPO, clinical process outsourcing, not BPO, for this exact purpose. It was, as I spoke earlier about the nurses leaving the bedside, working for hospitals, insurance companies, and third parties. We decided in 2010 that we should drive that remotely. It presents to our nurses a great career trajectory, because you still have a lot of people who sought nursing as a career to move to another country, the United States, most often for us. But now we have the ability for nurses to work for an American healthcare company abroad, be able to substantially improve their standard of living and remain with their families. So that's the outsourcing side of the business. So I will give you one number that between the two sides of the operation, we're closing in now on 5,000 employees worldwide. And the CPO emphasis for us today is exclusively in the Philippines. So we're looking at other countries where we might take that strategy and expand.
Okay, excellent. So that's helpful frame of reference. So the clinical process outsourcing, I guess, implies that it's clinical work. It's typical nurse work, but virtually done. And what levels of nurses? Is it all different levels? Are there certain use cases that you've found very successful, or what's the best way to think about it?
For us, the best way to think about it is as a company focused on expanding the size and the impact of clinical teams. What workflow in the remote case, what workflow requires a nurse by license, meaning the task is subject to a Nurse Practice Act, it's the practice of nursing. And then what tasks are important to healthcare outcomes, but don't rise to the level of the licensed practice of nursing. So there's a pretty big continuum of functions that have nurses who are Shearwater employees, the same as I am, living and working in the Philippines. They have a license in a state in America, just like any other nurse in that state. And our nurses in those categories will function on those workflow that require the license.
Right.
Go down from those kinds of roles, you get into a whole plethora of roles that let me just give you, for instance, you could have a clinical workflow that maybe has 10 steps, and completing the workflow requires a license to render that outcome. But you can't get to the last step without going through the first 3, 4, or 5 steps. And some of those steps might have an administrative component to them. And so what we get really excited about, or looking at workflows, can be bifurcated, where parts of the work can be performed elsewhere, so that the clinicians who are scarce can practice more at the peak of their license, the top of their ability with greater efficiency, and essentially have those staff performing those last few steps, knowing that the foundation of that work has been completed accurately somewhere else by somebody else. One of our team.
Yeah. So is it fair to say you're using technology, telecommunications, video, audio conferencing, data sharing, and under appropriate HIPAA controls and everything, in order to get everyone working at the top of their license. Because you're global, you can bring different levels of clinicians to bear for whatever those 10 steps are. You might have one that's a combination of some US people in the facility, some actual RNs in the Philippines, and some non-licensed, maybe a counselor, social worker, or administrative task in the Philippines or another part of the globe.
Yeah, and we hire nurses here in Nashville too. So we have clinical teams all over. For us, it matters more about the precision of your work, the accuracy of your decision, than the location of your desk chair. And so long as we can ensure security and compliance, then we look for where's the best place to do that work. And here's something that's been an unexpected benefit, are workflows that, because CPO in our Shearwater world runs 24 hours a day, the sun never sets on our work. And we've been able to rapidly accelerate clinical results for client partners that would otherwise wait a day or more to be completed. But when you blend teams, and our clients essentially run the day shift, we run the night shift.
Yeah.
We use the same IT platform, same rules. All of a sudden, the work product is just rapidly accelerating.
Yeah. Instead of having someone in Nashville working at 3 a.m. in a night shift, they're in the Philippines, or they're in New Zealand, or they're in the Mideast, or wherever. And you're able to stitch that together where the sun never sets on Shearwater.
Right. Or our clients.
Or for your clients.
And,
yeah, exactly.
And if the things that really excite us today are around driving this peak of clinical practice and efficiency that I spoke of earlier, trying to help enable hospitals to modify their care models. Remote monitoring is a big area for the company, and we're excited about that. But the real energy and excitement is around trying to create new outcomes that would be impossible to accomplish. And we think about people that are managing chronic illness at home, trying to age in place, whether it's hospital at home programs or just helping people thrive in their homes. We are eager to collaborate with people who have similar visions, and where the notion of driving whatever that outcome may be would require every nurse in, let's say, Nashville to be reassigned for that purpose. Well, that's just not going to happen in the United States or in any other city. So where could we throw some terrific technology together with thousands of nurses and make a meaningful impact in the lives of people who could benefit from it? That is really exciting, and is a big focus for our team.
Excellent. So you mentioned that the new graduate nurses that are just now getting out of schools and excited to start their career are not having a great experience. What are some examples, or why, or how's that occurring? And I just want to learn about that, because obviously we have a really bad turnover problem. But if we make all the new entries not happy, that's good. That's not going to get better.
Yeah, and I think it's great you're going to put the National Council study in the show notes.
So we can talk about it. People will be able to access it just by going to the show notes and clicking on it.
And it's certainly not true that all new nurses are struggling. I mean, what I'm hearing from CNOs, and over the last 2 weeks, I've spent 13 days in 2 different cities with a bunch of CNOs. I'll do it again at the end of the month through the Health Management Academy. There's been a difficulty for quite some time of nurses having preceptor arrangements within the acute care hospitals.
There aren't enough preceptors available, is what I have heard.
Well, and there's a lot of sick people who need care. Our hospitals are full. So when you're already running at 100 or more than 100% capacity, when you consider bedded inpatients waiting in emergency departments, you've got to focus on helping care for the patient who's in front of you. Now you're trying to help care for and train the nurse of tomorrow. That's a tall order. And during COVID, those slots were reduced even further. So I think that's made it difficult for new nurses entering the market. At the same time, COVID demonstrated to pharma life science, work comp carriers, traditional health insurance payers, and even providers that nurses can work from any location. So when I read this report from the National Council, I don't think, this is my sense, and I would love to collaborate and study this with someone. I don't think 20% rather of the nurses are going to exit the workforce, meaning they're not going to work as a nurse. I think they're going to take their skills somewhere else. And I think a lot of new grad nurses who are new into the field will do the same thing.
Yeah, they will still be caring for patients, but they might be doing it in a real patient monitoring company or an insurance company or a pharma company, helping with medication adherence and education.
All valuable tasks, really important. We look at those and think, well, if it could be performed remotely through technology and using automated intelligence. So we thrive just on the other side of where AI stops. So the automated intelligence may suspect an answer or suggest an action, but there might be 2 or 3 different actions suggested. And if Ted Merhoff's the patient, what's the best action for him and why? That is still a human decision that we think greater scale and efficiency to those decisions is a good thing.
Yeah, I mean, I am really excited and really scared about AI. But I think there's not going to be for a long time a replacement for the caring, empathy aspect of treating patients, right? Like that human to human, holding someone's hand, explaining what's going to happen in a way that they can look in your eyes and sort of feel that you care about them. That's really hard for an AI system to deliver. And even over Zoom or over the telephone, humans are very good at empathy, especially when they're trained nurses and have that sort of calling to do that. And so I think there's going to be, there'll be a role for AI, certainly, but the actual delivery of care and making judgment calls on which of 3 or 4 treatment protocols should be used in this case, I think there's going to be a long time where humans need to be delivering that care. I'm interested in your thoughts about, I haven't been able to find a study, maybe you know one, but being a nurse in an inpatient setting is a pretty hard job. It's 12 hours shifts typically. You're on your feet. There's a lot of physical activity. It's tiring for anyone. And I think there's a lot of nurses that would love to keep using their skills, but they'd like to not be running around on the floor and lifting patients. And as they get older, they don't want to do that anymore. Mm-hmm. And is there a role for your technology, your system to sort of plug them in as the really wise nurse that can maybe advise 15, 20 nurses that don't have as much experience, but are sort of willing to do the moving around the floor, and they're learning a ton from doing the care and hearing through teleconnections or video or whatever from the judgment of an experienced nurse. Does that exist, or could you put that together at Clearwater?
Vic, it does exist. People are doing it. We actually don't think it's a great fit for what we've created through our CPO platform. The nurses, if you're will be a coach to a new nurse, we think that's best delivered by a nurse who's worked in that local environment. So from a Shearwater Health perspective, one of our nurses working abroad would not be good in our estimation. Now, a Shearwater nurse who's completed 3, 6, 10 years of practice in the United States, we have nurses that have been here for 2 decades now. They are charge nurses and leaders, and even some of our nurses during the first couple of years are promoted. Those nurses would be great mentors. And I think what I think we'll start seeing more of, and my in is relatively small, but it's fresh because I've just talked to CNOs about this, are creating where hospitals are creating 4-hour schedules for some of these nurses that you've just described who would like to work, let's say, between 10 or 11 in the morning and 2 in the afternoon. It's an opportunity for nurses who are on the 12-hour shift to have a legitimate break while having someone covering for them, or having nurses that are mentors that are on the floor. they don't have to be there for an entire 12-hour shift, but they could be there in pockets, maybe helping nurses with report or helping nurses at the end of the day when the surgical volume is having a lot of admissions onto the floor. That's another area where I think
there's definitely peak busy times for the nursing staff. And if we can figure out the credentialing and the getting them scheduled, all of those logistical things, which can be challenging, I think there's a lot of benefit from having multiple schedule types, so that you might even be full-time in one system and then be willing to take some 4-hour shifts at another system because you want to meet some new people and you're being a mentor there. I think there's ways to sort of better use our nursing resources.
And a lot of people are spending a lot of energy on that.
Yeah. So tell me where you think this is headed, and where's this global care continuum process today, as far as how much it's built out, and where do you think it could go?
Well, I think around the world, one of the things that really was eye-opening to me 23 years ago are the way certain governments look at the production of nurses for purposes of leaving to go work in other countries. In the Philippines,
it's almost an export industry,
as are seafarers and other categories of workers. In fact, when you travel to the Philippines upon return and you wait in line to go through immigration, there's a line for the diplomats, but then there's also a line for the OFWs, the overseas foreign workers.
Yeah.
It's a prestige for people to remit money.
And it's a significant source of money going back there too.
But it's not an inexhaustible supply. So where do I think it's going today? Our company is not only in the Philippines, but in each of the other countries where we work. We're very sensitive about relationships with local hospitals, schools of nursing, and the governments. We want to make sure we're advancing the cause of nursing in each of those markets. In the Philippines, what you will see, it's already happened, but you'll see it more over the next few years. We're funding nurse tuition, helping pay for people to complete their nursing school, to get their bachelor's degree in nursing, try to drive more people into education. And then we are creating relationships with hospitals so that when nurses graduate, they're working at the bedside. Right. And what's in it for the hospital in that model is the visibility of knowing what that nurse's career pathway includes. Some of those nurses will work for Shearwater after their clinical experience in the Philippines as a CPO nurse. Others of those nurses will remain at the bedside. So we're more now about contributing to the.
Yeah, you're sort of lifting all, you're creating more nurse supply, more nurse talent. Some, like you said, you have your clinical outsourcing business where they can stay with their family there in the Philippines or in other countries. And it still is helpful to U.S. health systems. And then some will want to come, but that's a personal choice. You're not sort of dictating that. You're sort of adding to the educational resources, and it lifts all boats.
And we present options to people and try to provide a realistic preview so that nurses can make the right decision for themselves, for their families. I think that I hope that in a few years, we will see technology getting to the point where nurses remotely can make really meaningful impact in the lives and disease states of people around the United States, around the world, contributing to real world evidence and decentralized clinical trials for drug discovery. But for people in their homes, and people managing chronic illness, I learned something recently from a significant health system in the United States. They have ambitions for engaging with their patients to manage chronic illness in the home. In fact, the electronic health record that they've bought has a module that promotes chronic care management. This health system hasn't turned on that module because turning it on will create so much work. And their staff are already at more than 100%. And I just think that's a real shame that there's a tech platform that exists today to engage with people. They want to engage with people, but their practices are already so busy I wrote about this. These practices have full waiting rooms. They have full inboxes. The hospitals are full. The EDs are full. Like, how do you cram more people through that if you can't figure out a way to use on-site remote clinicians together with tech to help people manage an illness at times when they're not with their doctor? And I think that's my greatest hope for our company, for our health economy, that we're able to figure out a way to drive clinical improvements for people who need it, who aren't getting that today.
Yeah,
and you don't have to keep every hospital in Nashville to do that.
right. And there's going to be plenty of need for the hospitals still, but getting people in their home to manage the disease, maybe weave in a little prevention, or at least monitoring and diagnostics, try to help them with medication and exercise, at least walking around a little bit, diet. That can make a big difference to someone's life expectancy and quality of life. And keep people from coming in through the ED, which maybe is not the best outcome.
Here's another example, and it gets to the young nurse or the inexperienced nurse, not necessarily young, but just inexperienced nurse. We're doing some innovative work with a home health company now, where before collaborating with us, the nurse managers for this home health company spent a lot of time with their nose down in the chart, looking at plans of care. It was a paper and pencil or digital computer record kind of task. But what we figured out together with our partner is that work can be dispatched to someone else, us in this case.
Yeah.
And now that nurse leader, rather than spending most of the day reviewing plans of care, that nurse leader is able to round with the home health nurses going into the homes. So now is more of a coach, spending time with the nurses in the field. That is a terrific way to build a platform for clinical success. And while that nurse manager isn't practicing nursing in that example, they're much closer to the people who are. And we think more and more of that is
they're sort of leveling up, coaching, helping their nurses kind of begin to build their own judgment, understand the patient relationship, all the things, especially in home care, where you're going into the home, you have all kind of these other things that are challenges that kind of ride along. Even if you did it once every couple of weeks with one of your people, could really make a difference over time. And they don't need to be doing the plan review. Your team can do that cheap, better, faster. Global,
but where
you have to have it, it has to be accurate. You have to make sure there's nothing that was dropped or misinterpreted. But your team can do that at scale, and they should maybe not focus on that, and instead their highest and best use of sort of leveling up the whole care team.
Right. And Vic, when we got into this business, the CPO side, we had no idea there was this opportunity in home health. We weren't thinking about decentralized clinical trials or remote monitoring. We just came to the market with an idea that said, what can you do with highly skilled and a highly scaled clinical team that could drive impact? And the ideas have just been flowing in continually ever since. It's a lot of fun.
Yeah. Excellent. Well, Ted, thanks for doing this. Give people a handoff where I'll put this report, and also you mentioned the blog I want to try to grab from you about the nursing challenges. Where else? Maybe your website. What's the best place for people to learn more?
So SW Health, shearwaterhealth.com is the website for the company. And
if someone wants to hire you and bring you in to help with staffing and CPO and everything, they can find you on that website. Is that right?
Yep, absolutely. We'd be delighted to hear.
Are you taking new clients? Is that open? Are you open to that?
It has to be a terrific partnership. Sounds corny to say, but we know from experience where our nurses domestically will thrive. So we want to find communities where our clients will be a great host to the nurse and create an environment where they want to stay. So not every hospital fits that mold, but a whole lot of them do. So that's great. On the outsourcing side, it's more about scale and where can we create meaningful impact. And we'll work with startup companies, and we work with some of the largest companies on the planet And if those organizations have an ambition to make healthcare more efficient, to drive higher quality outcomes, and precision matters more than desk chair, those are great partners for us.
Okay, so let me try to recap to see if I have this right. On the long-term international recruiting side, which is a not traveler, but several years recruiting process, it's a true partnership. You need to have a good home for your nurses who you're moving across the world to locate there. There's a lot of places that need nurses, so you want to make sure you have a good partnership and it's a good place for your nurses to spend their career or spend a part of their career. So the health system has to be willing to partner and build that culture.
It's so easy, Vic, because it means treating a Shearwater nurse like a full-time nurse. It's you're not calling them a travel nurse; they're there for their career. So it's so easy to be a great host.
It's easy if they have the right attitude and they want to be that way. Which I think the right health systems will want to do that. And then on the clinical process outsourcing, you're trying to learn and build partnerships, and you have this resource globally and technology to really give precision nursing virtually. And so you're open to sort of all different kinds of partnerships that could utilize that.
Right. Nurses, but also, Vic, we have pharmacists, therapists, and physicians that work in that platform too. So it's really it's a vibrant clinical human capital resource that is eager to help make a difference.
Well, Ted, thanks for doing this. I'm super excited about Shearwater. It's been fun to see it evolve over time. And I think you are right in the crosshairs of like the biggest need in our healthcare system around workforce, getting the best nurses, the best staff in the right place to do the most good. So thanks for everything you're doing. I'll put links to your website and the report in the show notes, and hopefully we'll get some more people on the platform doing good.
Well, it's great that you're doing this podcast, and I hope people enjoyed listening.
Yeah. Okay. Thanks, Ted. Appreciate it.
Thanks so much for tuning in to this episode of Human Centered Health. If you are enjoying the show, please feel free to rate, subscribe, and leave a review wherever you listen to your podcasts. This helps others find the show, and we greatly appreciate it. Once again, thank you for joining us, and we'll catch you in the next episode of Human Centered Health.